Hello, I'm Bob Falcone, CEO of the Columbus Medical Association and its affiliates. One of those affiliates is the Central Ohio Trauma System. COTS was tasked with organizing pandemic response for regions 4, 7, and 8. That's Central, Southeastern, and Southeast Central Ohio. The governor combined those regions into Zone 2 and asked Dr. Andy Thomas, our guest today, to lead the effort for the governor and for the state on our pandemic response. Today, we plan to do an update on where we are and where we're going. Andy, thanks for joining us.
Thanks for having me here, Bob.
Where are we? What's going on?
Well, I think if you look at the pandemic from a total cases perspective, since probably a low point in mid-May, late May, new cases have certainly been on the rise over the past month, starting in about mid-June. I think the difference between this time and, say, April is a number of the cases tend to be in a younger demographic. So it's a little bit different type of patient that's getting sick. We're not seeing the types of infections we saw in congregate settings, large nursing home population, large prisons and jails. We have still some elderly patients that are getting ill, but in general, the major change in terms of the demographics for the cases are that younger people are more likely to be infected than they were likely to be infected in the first round of this. Why that is, there's a lot of debate. I think people feel like sometimes folks in that age group feel indestructible. It's not going to be a problem for them. To some degree, that's true because they tend to not have the health complications that older people have, but obviously they can carry the virus and infect other people, which is the concern. So on the total cases side, we are as bad, if not worse than we were in the spring, depending on how you look at the community spread versus the congregate care setting or the prison setting. In terms of the hospitals, though, I think it's a very different story. I think our census is on the rise, has been on the rise for about a month, but we're still sitting well below our peak census from late April, early May. We're probably about 80 patients lower than where we were as a region for the peak census.
80 COVID patients.
80 COVID patients, yes, thank you for clarifying. But if you look at the percentage of those COVID patients who need an ICU bed or need to be on a ventilator, it's far lower as a percent of the total COVID census than where we were when we had a more elderly, more chronically ill patient population, say in April and May, who were getting sick. Then now some people may need to be in the hospital, but it's a slightly lower age group and slightly lower comorbidities. And at this point, it doesn't seem like we're having as much of a rise in ventilator cases or ICU cases compared to total patients.
I keep hearing and seeing reports that we are pretty full as hospitals, but that's kind of business as usual for this time of year, isn't it?
It is. I think the Central Ohio hospitals, especially in Franklin County, tend to run a weekday average, census in the 85 to 90% full. So that's not too surprising. We do look at the bed capacity across the zone. So, for example, there are a couple of hospitals in contiguous counties to Franklin County that are running a little more full than they usually do, but not to the point where you can't get care there. So I think that in general, if you're a COVID patient or a non-COVID patient, we have more than enough hospital capacity at this time to take care of anyone who needs care.
It appears to me, looking from the outside in, that the mortality rate is less for the current population of COVID positive patients. I assume some of that is youth and health. But you do have some treatment options that are starting to work out, I think.
Certainly. In terms of the mortality rate, it's certainly a lagging indicator. So I think we're always worried that if we see cases go up, hospitalizations will track that, then mortalities will track after that. The average patient who passes away in the ICU, for example, is typically not there for hours or days. They're there for weeks. So we may see that still as a lagging indicator, but you're exactly right. When I talk to our critical care docs, our infectious disease docs, our pharmacists, they feel that there's a kind of a menu of treatments that something's working better than it was before, and it's a combination of convalescent plasma, remdesivir, IV or oral steroids. It's really a combination of multiple different types of therapy that they think are having some benefit.
Early on, remdesivir was precious, and we got together under your leadership as a zone and shared it and made sure that if somebody needed it and somebody didn't need it, the remdesivir got to the right place. It's more available now, but it's going to be pretty expensive, best I can tell.
Yeah, of course, for a patient, it'll be about $6,000. Obviously, that is not separately reimbursed from the DRG. It is an IV medication, so it's really only given to inpatients. But around $6,000 for a course of medication is quite expensive. Now, the federal government, part of their rationale with this is they say it shortens the duration of the virus. It might shorten your length of stay for those patients in the hospital. But I think the devil's in the details on how the math is going to work out on that one. But remdesivir, I think, has been a great partnership across the zone. We've had, as the number of cases have gone up, we have more hospitals now that are getting allocated remdesivir. We initially were allocating based on ventilator days at each hospital. Now we're allocating just on total patient days. So as you mentioned, we've had, I think, 4 or 5 now zone-wide conference calls, even some folks from Cincinnati participating with infectious disease docs, critical care docs, pharmacists, ethics leaders, because whenever you're looking at allocating a scarce medical resource, those first shipment or two, we had far more patients that qualified for remdesivir than we had drug. Now it's a little bit in the opposite scenario. Most of the larger hospitals have a bit of a stockpile that we can use both internally in our environment, but to your point, the Ohio State Highway Patrol has been excellent at delivering to Portsmouth or to Gal Police. When a patient had no other reason to transfer to Columbus except to get remdesivir, we just brought the drug to the patient instead of moving patients halfway across the state.
So for those watching, the bottom line is if you need this drug, it will be available.
It should be. It should be. And that's really my counterparts in Zone 1 and Zone 3 have similar systems set up. So anywhere in the state of Ohio, I can vouch for the fact that if you're a hospital that needs it, we can find a way to get it to you. Outside the state of Ohio, obviously, each state's kind of handled this differently.
The governor and the Ohio Department of Health, and I'm sure you were part of the discussion, established a color coding for severity of COVID infections by county.
Sure.
Can you explain that?
I can. I think, first of all, just to step back philosophically, I think some of the original orders to the stay-at-home order and the business shutdown order were very, very necessary back in March when we were trying to get our arms around what this virus was. At the same time, obviously, there was some criticism as the stay-at-home order went on through the month of April. There were some rural counties that had very few cases, and I think some folks are saying, well, we don't have much here. Why does this apply to us? And because the original orders were spread like peanut butter across the slice of bread, everyone the same. And the philosophy behind trying to tailor the color code for a county to the outbreak as it was being seen in that county was trying to be a little more surgical as opposed to a blunt tool, a little more surgical and nuanced to try to really highlight where things were a problem, and also to try and help educate people. I've used the analogy of a weather forecast, that it doesn't help me to have a weather forecast tell me it's raining when I can look outside and see it's raining. So what we want to try and do is broadcast ahead of time. Your county has indicators that are saying this is coming. And from yellow to orange to red to purple, it's really a warning system to get people to pay attention, to get people to wear a mask, to get people to respect the social distancing, and to have people, even in some rural counties, Trumbull has flagged, some other counties that are small town, more rural settings, to say, this can happen in your county. By the way, it is. Look at the data. This isn't just something in Cleveland, the 3 Cs, Cleveland, Cincinnati, and Columbus. So I think the way the metrics are designed, some of them are leading indicators, some are lagging indicators. So for example, on the lagging indicator side, there are 2 hospitalization metrics. Hospitalizations happen usually at least 2 weeks after someone's become ill. That's showing that the disease is here and it's taken a foothold, and now we're seeing hospitalization issues. But the leading indicators really are around the ramp up of people presenting with what's called usually it's called ILI, or influenza-like illness. So all these viral illnesses have the same symptom. So people are presenting to their doctor or to the ER with symptoms of one of these illnesses. And we know, because we track that for the flu every year, we know what the numbers should be this time of the year. And we were able to compare that with a county and what their numbers are at baseline. So if we see those numbers start to go up, that's a leading indicator that more people are seeking care. their test might not be back yet, but they're seeking care. And then certainly a ramp up in cases when we look at on a 7-day rolling average to look at 5 days of increasing case numbers over the last couple of weeks, last 3 weeks is really concerning. And then the last two metrics are cases per 100,000, which is a way to kind of normalize small counties and large counties in terms of the metrics. And then the last metric is has to do with congregate settings. So if in any one of the last 3 weeks, over 50% of the cases in that county are not in a congregate setting, it flags, because that shows there's community spread. We didn't want to target a county as red or purple when it's just in a local prison or maybe 1 or 2 nursing homes and not a widespread issue in the county. So the goal is to have 7 metrics if they're directionally pointing the same thing, because any one metric, you could find a scenario where that metric doesn't work. You can bicker about any metric, but if 4 or 5 of the 7 are flagging in the wrong direction, you're going to be red. If 6 or 7 flag, you're going to be purple.
And we have several red counties in our zone, don't we?
We do. Franklin County has been red since the first week in both Licking and Fairfield. I'm trying to remember if Delaware went red or not.
Yes, I think they
believe
did.
it did. Yeah.
Where are we with masks? Do you think the governor's going to come out and say, hey, I don't care what color you are, what color your zone, what color your county is, wear a mask?
Actually, he just did that today. So that we're recording this on Wednesday afternoon, and the press conference that just happened about an hour ago, he did come out with a statewide order. I think if you look at the tactics that both the federal government is recommending as well as what other states are implementing, one of the goals that the governor and the High Department of Health team has had all along is to not wait till the horse is out of the barn to do these things. If you think about when we shut down spectators at the Arnold, when we closed K through 12 schools, closed our colleges and universities, Ohio State announced that we were making spring break 2 weeks long, a week before, 6 days before the first case was announced in Central Ohio. We did all of those steps were to try and take them as early as possible so that it wasn't out of control by the time we took those steps. And I think that face masking is the same. We are not in as good a position as we were at the end of May. But we are nowhere near where Arizona, Florida, Texas, California, Georgia are now. And we don't want to get there. The phrase I've been using with people is, let's not do this after the horse is out of the barn, but I hear it kicking the barn door. I hear it kicking the stall. Now's the time to probably put some of these things in place. The downside of that is the critics will say, see, it wasn't a problem. Well, it's you're a trauma surgeon. It's like wearing a seatbelt. Well, if fatalities and injuries from car accidents went down, you wouldn't say, well, it's not a problem anymore, take the seatbelts away. That doesn't make any sense. That I think the benefit of messaging around face masking and now an order has been that hopefully we won't be at 18, 19, 20% positivity rate, and we'll stay in the 6 range or go back down to the 3 range where we were 6 weeks ago.
And the masks do work. There's enough data to say that they do work.
They do. They're not perfect. I think if you look at the combination of a mask, social distancing, washing your hands, and cleaning high-touch surfaces, those 4 elements, they're like Swiss cheese. We talk about medical errors and patient safety with Swiss cheese, that it's the same sort of thing. To get the infection from me to you, if I have 2, 3, or 4 of those things in place, it's better than having 0 or 1, but no one thing is going to be perfect. So the mask, when you think about it, surgeons have worn them in the OR for 100 years for a reason. It's not because the surgeon particularly needs protected from the innards of the patient, but obviously what's coming out of the surgeon, out of the nurse, out of the anesthesiologist has a risk of infecting the patient. So it's the same concept in this case. The other flip side is that there are some critics who worry that somehow the person wearing the mask is going to be injured by doing that. And certainly there might be some rare circumstances where someone has bad enough lung disease that might be an issue. But on average, for the average patient, much like nurses, doctors wear these for 6, 8, 10, 12-hour shifts in the OR or wherever they may work, and they're not passing out right and left from high CO2 levels and low oxygen levels. So
and they're not all healthy either.
Well, that's true.
There's some of the surgeons and other personnel are older. They have some comorbidities, but the mask doesn't really seem to be much of a problem.
I think
if
the
you
other
wear it.
really good thing that we've seen over the past week is a number of national retail stores that have gotten a little more serious. I would say all the retailers have done a great job with their employees. That's who they can control more. Some of them have been a little more hands off with customers or patrons. But I've been very impressed, both in the retail sector as well as I did a webinar yesterday with the Ohio Restaurant Association. They had a couple hundred members on, and they're really just trying to learn, what can I do to keep people safe in my restaurant? Because the flip side of all this is, if we don't keep people safe, people don't wear a mask, people don't distance, then you are going to be in a situation where things need to be shut down again, and nobody wants that to happen. So this is like preventive medicine. Let's not wait until we have a problem. Let's try and stay ahead of it.
Even if our rates go down and our hospitalizations go down, I don't anticipate a change in masking this year. Do you?
I think until there's a vaccine that's in widespread use, even if we have a vaccine in the first quarter of next year, they're not going to produce 11.7 million doses of it and drop it in the Ohio Department of Health's lap. I mean, there's going to be a slow rollout of this over time. But I agree with you. Until we have a widespread, what would be considered a pharmacologic measure, either a medication that's beyond the medications we have now, that's truly a silver bullet, or a vaccine, or both, we're not going to be getting out of this anytime soon.
And one advantage for us in medicine is that if people are wearing their masks, they may actually get less flu, regardless of whether they've been vaccinated or not. They should be vaccinated, but wearing a mask, I think, will have some benefit there, don't you?
Well, I think it will. I also think this is going to be a banner year for flu vaccinations. People are going to be clamoring for it, especially if this fall there still isn't a COVID vaccine, because nobody's going to want to, get sick with one or both. I can only imagine what that would be like. But I think you're right. Because people are going to be wearing masks for COVID, it will also reduce the burden of influenza, I would expect this year, hopefully. And that plus vaccination.
I'm reading a lot of very positive stuff about vaccines even this year, but I think your point is important. The vaccine may exist and it may work, but making it is a whole other situation.
I think the good news is there's multiple people that are in process. There are kind of multiple horses, and I have a feeling that more than one of them will probably be found to be effective, and we'll end up with multiple options for vaccination. I know at Ohio State we're getting involved in 2 or 3 different vaccine trials that'll be kicking off here this fall, where we're doing essentially kind of phase 3 work with vaccinating folks locally. So more to come on that, but I think the other good news from what I do understand is from a financing perspective, the federal government's made a big bet, obviously, on this, and that they're probably going to start producing the vaccine even before it's approved. In other words, instead of doing things in serial, or they'll do them in parallel instead of process-wise serially. So,
which really shortens the lag time to getting it out.
It really should. It really should.
Do you anticipate a similar distribution mechanism to what you have for remdesivir?
So we've had a couple of discussions with the Ohio Department of Health about setting up some sort of a process. We don't know how the federal government's going to handle it yet, but I would expect, given that different states have really the distribution mechanism, for the federal government to send it to any one hospital, I mean, that just doesn't seem to make sense. I have a feeling the federal government will distribute it through the states, but we don't know yet. But I think that's a discussion to start having long before it's available.
We just recently stood our combined call center activity back up.
Yes, we did.
Really, in my mind, it was as a precaution. But your team at Ohio State and Ohio Health and Mount Carmel stood this back up within a matter of minutes, literally, which is really pretty exciting.
The partnership, I mean, as I know you've had all of us here previously, but the partnership that we're lucky to have at the medical administrative level is wonderful in this community. And you're exactly right. We made the decision actually about a week ago to stand back up the Unified Transfer Center. That allows any hospital that's calling any of the 3 transfer centers for the adult systems, if they have a COVID patient, they go to this centralized group of folks that are communicating 24/7 through a WebEx call. So that if we need to load balance, if someone's gotten 3 admissions in the last 2 hours and they say, wait, we need a little break, We can move the patients between systems if any hospital reaches capacity. We can partner through that mechanism. As you well know, because you're on the calls, we're now on the phone 3 times a week as a large group, including hospitals from Steubenville, Chillicothe, other parts of the state. So I think that the partnership's really just been outstanding.
We use that same partnership to stand up a field hospital at the convention center. Over the last couple months, we've slowly decommissioned that facility. The space is on hold, and the decision on releasing that's really going to be a combination of discussion between the hospitals and the county and public health. But the good news is that everything we decommissioned, with a few exceptions, is in storage.
Correct.
And we could put it back together in a week. So.
Yep. I think that work that went from 0 to 60 in 2 weeks was just amazing as well. I'm just thankful we never needed it, because I think as good as the plan was, as prepared as we were, if we got to that point, the burden of illness in this community would be so high that it would be almost unthinkable. And
it would truly be a disaster.
It really would. It really would. As good as the care would have been, and we would have done our best in that setting, just the impact to this community would have been more than I can even think of. But luckily at this point, we aren't even back to where we were with our census, and we weren't close back in April to needing it. So I think as we've talked about many times, we plan for worst case scenarios and then do everything we can to avoid getting there. And that's really the situation I think we were in with the convention center.
Our time together has made me much more optimistic about the future. How about you?
Yeah, I actually am pretty optimistic in general about really the skills of the doctors, the nurses, the pharmacists that are at the bedside at all of our hospitals, in emergency departments, the folks that are at the swab sites. All the hospitals in town have swab sites open. I think that the commitment of the professionals that I work with every day I've always known it's high, but when you really see now, we're kind of in the maybe halfway through a marathon. This isn't a sprint. That first week or 2 weeks, anybody can be committed for a week or two. But now we're heading into really the 5th month of this work, and I've just really been so impressed by my colleagues, not just at Ohio State, but around the whole zone. Certainly in Central Ohio a lot, but really in Cambridge and Zanesville and Marietta. I get to talk to all of them, and I've just been really impressed with how we as a healthcare community have come together to attack this and partner together.
All good news. My guest today has been Andy Thomas, Chief Clinical Officer for the Ohio State University Wexner Medical Center and the Governor's lead for Zone 2, which is our area, Central, Southeastern, and Southeast Central Ohio. Thanks, Andy.
Thanks for having me.
This is Bob Falcone, Columbus Medical Association. Till next time.